Welcome everybody to the Understanding Inpatient Cost Outlier Claims webinar. I'm Tom Ryan with Provider Outreach and Education. I'll be your presenter today. Today I'm joined by Ellen, among other members of my team. Ellen will act as my technical assistant. She's going to monitor that chat, read me questions, try to get you through anything you put into chat. But again, don't forget to email us if you are having technical difficulties. Inpatient outliers was something that you have asked for in multiple surveys. So this is why we put the information together. It is something that we did a few years ago. So we looked at the information, made sure it was all current, and that's where this came from. So this is actually in response to what you've asked for on the surveys. All right. Always got to start with a little bit of a disclaimer, so I want to give you some basic information. As I just said, we looked at the information, we prepped it, and we got it the most current that we could. However, please keep in mind that the CMS website contains the most current rules, laws, and regulations. We do offer guidance on our website, but CMS is the one you want to go to for all of that. Remember, Medicare changes frequently, so check that website. Make sure the information remains current. I did the best I could to verify everything was current as of this morning. There were some questions submitted. Again, I built these questions into the presentation as much as I can. If you still have questions remaining or I missed something, we're going to have you put those in chat. We're going to answer those later. However, remember that I can only give you the information based on the question that was asked. So I can't interpret, I can't guess my way through it. Pretty sure I got everything, but if there's something you need clarification on, throw that in the chat. Last, CMS does prohibit the recording of this information for profit-making purposes. Because we cannot ensure how you're going to use our recording, we ask that you do not record at all. Here's what we're going to do instead. We're going to record it. We're going to put it on YouTube. Then once it's on YouTube, what we'll do is make it available to you. We'll notify you. We'll add it onto the Encore playlist. So please take the opportunity to look at that. Keep in mind the Encore playlist, the link directly to that is available in the chat for you right now. All right, a little bit about today. Today, my goal is to help you understand inpatient outlier claims and how to correctly handle them. How are we going to do that? I'm going to provide a basic definition. We're going to get started with a basic definition of outlier claims. We're going to get started with a basic definition of benefit period and move through some things like that. Then we're going to put the pieces together so you can get some coding information. Then I'm going to display, use some slides to display and hopefully help you get a better understanding of everything. So our goal is to get you to build those inpatient prospective payment system, IPPS, inpatient outlier claims correctly. Now, outlier is the high dollar outlier. We're not talking about the low dollar one today, just the high dollar one. Too much information when we tried to mix the two, so we actually are not going to talk about that today. Also, if you do not bill an inpatient prospective payment system claim, this is not a webinar that will help you. So if it's not something you bill, and we did have some questions that came in that said, well, what is an outlier? Why would I do this? And one of those came from a critical access hospital. Critical access hospitals do not bill this payment methodology. You bill or paid on a different payment methodology. Therefore, this information is not applicable to you. We also had 3 skilled nursing facilities that asked me questions. Skilled nursing facilities do not bill under the IPPS, the Inpatient Prospective Payment System. They bill under the SNF PPS. So this information does not apply to them. So I'll make that as clear. If this doesn't apply to you, please, don't sit and listen to the whole thing. I don't want you to spend your time for something that's not going to be helpful to you. So let's get started. As I said, the first thing we really need to do is get some definitions. Now, these definitions were built because people ask questions, and based on the questions they were asked, I realized we needed to step back and start at the very beginning for people who had almost no knowledge of what the inpatient prospective payment system is, how it functions, how Medicare pays claims, things like that. So that's where these definitions came from. So keep in mind, I'm going to try to hit all those different questions. But again, if I miss your question, please feel free to put that in the chat for me. All right. The first question that came in is, what's the difference between a benefit day and a benefit period day? Now, they were obviously looking at some of my information from an article or from this training, and they were a little confused. So let's explain the difference. A benefit period day is the entire encompassing whether Medicare is paying or not for an inpatient prospective payment system. So it's 60 full pay days after deductible applies. So deductible first, full pay days. Then we've got 30 coinsurance days. So it's a total of 90 days. Deductible, then up to 60. Medicare pays 100%. Then at 30%, we begin to put coinsurance. Could be called a copay. Then once you reach that 90, that ends those payment days. Now, on an inpatient hospital claim, you also have the option for the patient to elect 60 lifetime reserve days. Now, these are elected days they can use. I want you to circle the word lifetime because once they're used, they're gone. Okay? They're just gone. So that is what a benefit period is. Now, when we talk about a benefit or the benefit day, like the actual payment day, any of these would be a benefit day. However, a patient can remain in a medically necessary stay for longer than benefits are being paid for Medicare. So Medicare benefits end after either 90 or 150 days, but they're still in a medically necessary stay. That's when we wind up with the benefit period continuing. So it's a longer period of time than necessary or a longer period of time than Medicare is paying. So benefit period could be shorter, could be the same amount of days that Medicare pays. So if you're only in for 30 days, your benefit period could be 30 days. Okay, so you're only inpatient for 30 days. However, if you're in for 180 days, you're only going to have the 150 days of coverage. At best, maybe 90 or 150, depending on whether or not they elect those 60 days. What ends a benefit period? A benefit period can last an entire lifetime. I want you to keep that in mind. There can be one benefit period per lifetime because what has to end it is a 60-day lapse in inpatient care. Why is this so important for outlier claims? Because the benefit period starts a new calculation for the inpatient prospective payment system. So when you look at how a claim is paid, it's the new of. So a benefit period can continue on. An outlier claim could actually not be paid at all. We could also hit certain points, and we're going to talk about some of those points where, hey, because the inpatient prospective payment system isn't a daily base, right? It's not done on a day-by-day basis. Instead, it's done on a diagnosis basis. There's a period of time when it's actually part of a benefit period and it may not be paid. So we're going to talk about a variety of different factors that function into that. So remember, I just told you a benefit period is not paid based on a day-by-day amount for a hospital. Now, keep in mind there's other ones that are. Critical access would be one. We're talking about inpatient prospective payment system. We're not talking about critical access hospitals. Instead, Medicare does pay based on the Medicare severity diagnosis related groups. So this is where your payment comes from, and this is why you have a lump payment. Payment covering everything versus you get $20 a day or $50 a day or whatever that per diem is. So when we look at a severity diagnosis related group, this is where we have set amounts. And it says, okay, this is what this diagnosis pays. We're going to base that on your primary diagnosis, your secondary, your procedures, your sex code, your discharge statuses, a variety of other things all figure into that formula. Now, once we reach the top amount of that formula, that's where an outlier begins. So you have an inlier and an outlier portion of your claim. Now, an outlier, we're going to use, again, the high dollar outlier for this one. Okay, so the diagnosis is based on that. Key things to remember about the MSGRG is that, one, it has to have a utilization day. This is the day that uses a benefit period and is counted in the common working file. Those who don't know what that is, it's just the master file. It stores everything. It maintains and tracks the beneficiary information. It tracks the Part A and B claims, coordinates them together, all of those different things that go together. So when we're looking at the common working file, we do have to follow a midnight census to determine which days are included. Now, why is this important for a utilization day? Well, if they're on a leave of absence, in other words, at midnight, they're not in the hospital, maybe they had an ER visit, maybe they're doing something outside, a test or something, so they're not in that hospital, then the hospital would bill a leave of absence, which would be a non-utilization day. Okay? This is not a discharge, because obviously they're not in the hospital on the day of discharge, right? We know that, but this could include that. That would be a day when, it's a discharge day. So when we look at these utilization days, they also play into the fact of the amount of money you're going to get paid if there's certain days missing and other things like that. So now it's not necessarily we're going to remove or take money away, but it's the length of time in which, right? They don't count against those 60, those 90, those 30, all of those different days. So a utilization day is when Medicare is actually paying for a benefit on that day. It doesn't affect the benefit period. Remember, a benefit period is a longer period of time than just the days that we pay for, and you have to have that 60-day lapse. Usually a 60-day lapse indicates a discharge has occurred. Now, there's also something called an inlier day. Now, this is the period of time that you're getting paid for during that MSDRG before you reach that dollar amount threshold. Because remember, it's set up to be one big payment for an MSDRG. And this is how much you're going to get paid. This includes everything you're talking about. So it could be your full pay days, your co-insurance days, could also be those lifetime reserve days, could also be after some benefits exhaust, because the payment doesn't stop or isn't reduced just because those benefit days are done. However, an outlier would be. So an outlier is going to affect differently. So we're just talking about inlier. A couple people have asked for some additional resources on and how to locate those inlier stuff and what actually is the price of the inlier days. That's all done in the direct data entry. Hopefully you have access to this. If you don't, it is a system you can access through the physical intermediary standard or shared system, the Part A system, and you have to be granted access, all of that. But there's a screen in there called the pricer screen. The pricer screen is what tells you what is considered an inlier and at what point a claim, when you reach a dollar amount, will become an outlier. Remember, it's not about the number of days. It's about that dollar amount, that point. So that's where you're going to look. And I gave you a couple of different pieces of information to help you utilize those if you need to. So what you're looking at is inlier, the days, the dollar amount that is before you reach that threshold. To calculate the threshold, you have to use the pricer because the diagnosis, the order in which those diagnoses, those all affect the total dollar amount that should be paid. Okay? Then we move on to the outliers. Now again, this is that additional payment representing the portion of the hospital claim exceeding the cost covered under the MSDRG. So the MSDRG is a standard formula that's going to pay you for the standard utilization based on the diagnosis codes. Once you reach the standard height level, the top level, now you're going to get an outlier payment. It's that extra money, that extra cost that you've incurred that Medicare didn't figure for. Now again, in order to determine where that dollar amount is, remember I just talked about it on the previous slide, you got to go back and use that pricer screen. I do recommend that you get used to using that if you're interested in outlier payments. A couple things to remember, if you're using the pricer screen, it's the same thing we use. You're actually accessing the Medicare system. So Medicare systems do figure outlier claims without you guys doing anything. So we'll talk more about that, and we're going to talk a little bit about some of those different types of things coming up next. So Medicare does recognize two types of days, and we've talked a little bit about this, but I want to make this as clear as possible when we talk about outliers. A utilization day is a day that uses a benefit period day. In other words, part of that 30, 60, and that additional lifetime reserve 60. So it's part of those 150 days. It is counted in the common working file. A non-utilization day occurs during a benefit period, but doesn't use one of the benefit days. So that again, a non-utilization day occurs during the same benefit period, but does not use a benefit day. In other words, Medicare is not paying for it. Okay? But because of the way the MSDRG figures the dollar amount, because again, it's not figured based on a daily, it's based on those diagnosis codes, the resources used, all those things that you're going to put on the claim. That's why you got to use the pricer. Non-utilization days are also covered under the MSDRG payment. So the inpatient prospective payment system also counts those. They're not a separate payment. Here's the difference. The non-utilization day doesn't count in the common working file. The utilization day does. And how that works is how much Medicare will pay for in the future. Because a benefit period covers skilled nursing facility, inpatient psychiatric facility, inpatient acute care hospital, all of those different prospective payment systems that go with it, that's what we're working under a benefit period. That's why it's no inpatient care for 60 days. No medically necessary inpatient care for 60 days. So when we're talking about this and we're talking about the outlier, it's that non-utilization day. Yes, it still counts, but does it count against that benefit period? And the answer is no. Hopefully all of that makes sense. If not, I just got through some base definitions. I haven't gone through a whole lot more than that. Throw those into the questions area of the chat, and I'll get those answered for you. All right, let's move on. I don't want to take too much time here. Next is claims, and this is where we're talking about some coding information. So keep in mind when I talk about the claims information, it's very key to understand that you still have to meet all the basic claims criteria, right? You still have to be able to identify the patient. You still have to use your NPI to bill. I mean, all of that basic stuff still has to be met. So I don't want to take that away. But what we want to talk about is how do we look at what needs to be coded on the claim for a benefits period or for a outlier claim during a benefit period. A couple of key things. There's going to be someone to tell you you don't code, the system will code it, okay? There's going to be someone to tell you, hey, I need this here to tell us this, so that we know what this is. All these different things need to play together. We're going to get through that during this coding section. Now, this does not affect if you needed to put a procedure code or the total overall payment. None of that's affected. Okay, none of those are still your charges. Those still go on the claim. So let's get started with some basic coding information for outlier claims. First, condition code 61. This is the one we get a lot of questions on. The claim hits the fixed threshold. Remember, the fixed threshold is what the direct data entry system is going to give you, but what our system will calculate. It's that threshold. It's what you're looking at. The system tells us when it hits that threshold and when you're above that. So it enters condition code 61 to say to start considering an outlier payment. Did you guys catch that? The system enters this. We had a question come in from the provider that said, well, I automatically go in and adjust my claims and remove condition code 61 because I didn't enter it. Don't do that. Don't do that. You're literally not going to get your outlier payment if you take this off. This is the way the system tells us, hey, I used the calculator, I figured everything out, and oh, you're going to have too much utilization, so we're going to put you into that outlier, that overpayment area, that extra money. So you take condition code 61 off, and the claim pays at the top of the threshold amount, which is, again, just that one payment you're going to get. So if you see a 61, don't take it off. Make that as clear as possible. Again, that's based on the question that I got about that. Occurrence code A3. This is the last day benefits are available. This is the benefits exhaust day. So this is the last day Medicare can pay. Now remember, we said it was so it's 90 days to start with, right? Because you have 60 that are the free days after deductibles met. Medicare pays at 100%. Then you've got the 30. Well, then you also have to look at whether or not the patient elected those extra days, those lifetime reserve days. So whenever those benefits exhaust, that's what we're going to use in A3 for, and we're going to put that date on there. Occurrence code 47. This is the date the threshold is reached. Now, once again, you're going to go into the system. You're going to use that calculator. You're going to look it up, and you're going to figure it out, and you're going to say, this is the day we reached the threshold amount based on the dollars that we've spent, based on the dollars that we've used, based on the dollars that we're charging. So that way Medicare knows, hey, this is within the threshold. This is our inlier days, but this is our outlier days, and this is what you should consider more money for. So it's your responsibility to make sure you are determining that. And that's very important to have that date on there. Without that date, we will have some issues. Occurrence codes A3 and 47, you're going to add to an outlier claim in one of these two situations. So add these. There are enough full or co-insurance days to cover all medically necessary days. In other words, we're going to continue to pay through the entire time of the claim. There are only available benefits for lifetime reserve days, but there are enough lifetime reserve days to cover all medically necessary days. So they've already exhausted the original 90 inpatient days. Now we're going to hit the lifetime reserve days, and the patient says, yep, I want to use them. There's enough of those lifetime reserve days, 60 lifetime reserve days, to cover all of the costs. Without that, remember, the original payment comes in, it is what it is, and we're good. So that's where we talk about it is a dollar amount set by the system. It's not a per diem amount. It's not a per day amount. It's a dollar amount set by the system. And that's why you're doing this. You're saying, hey, I know this whole thing is medically necessary. I also know there's enough days to pay for the whole thing. It is a utilization review system that will be communicated back to the common working file to help us understand what's going on. Okay. That's the goal of that one. Next is occurrence span code 70. Now these are non-utilization days. These are days that you're not utilizing any benefit period, but they're still covered under the MSDRG. So if you want to think about that, it's outside the use days. There's not going to make a payment for that. Yes, it's medically necessary, but it's still part of that whole stay. So non-utilization days. And you're going to want to put the span code on there so that we know what the days are. Like, what are the days? What are the dates? Okay. Value code 17 indicates the outlier payment. The system calculated and entered. Did you notice again? System calculated and entered. So what this means is when we do have something above that date, and you told us it's this amount of days by entering the code, right? We want that they then utilize the correct number of days to get paid for, which is how the system calculates it. So instead of just saying, hey, there's 120 days total, 60 of those are within the threshold or the inlier days, but then we also have 60 as an outlier days. That's where we're looking at that. So there's a very key thing there. Now keep in mind, non-utilization days are a little different, especially during some of the in-between stays. So yes, we continue. Yes, the patient's benefits are exhausted. I understand that. So they're at that 60 point, the benefit, a non-utilization day would be a day when, yes, you're still getting paid, right? You're still going to get paid because remember, it's a flat amount. It's not a daily basis. So they're in for 60 days, but they only had 45 days of payment left. Well, then after that 45 days, they're still in a medically necessary stay. That would be a non-utilization day. We're not utilizing any benefits. Also, let's say that that's a day where at a midnight census, they were in the ER. So they're not in the hospital that day. You didn't discharge them, and they came back the next day. So they went into the ER, or not the ER, they went into some service. A testing facility is actually a better example than an ER. So they went in for this test, except the test wasn't available at your hospital today, so you sent them over to this other hospital, and they're going to bill for that test. That would be a non-utilization day. It's a leave of absence day. So hopefully that kind of makes sense. So when you're looking at the value code, it's going to look at the outlier payment, but it's also going to look at those non-utilization days and say, we weren't here for this. This isn't a resource utilization day. And so that's how it has to work together so that you can get this value code. That's why you have to enter certain key pieces of information. Hopefully all of that makes sense. So all of those different value codes are used, occurrence codes and span codes are all used for different things. Now remember, there are two of them that you don't enter. 17, this is your outlier. You also never want to enter 61, but also don't take it off. Same thing with 17. Don't take those off. Those are the ones that are going to get you the extra money. So when you take them off, you wind up with some different items. Okay, let's keep moving forward. So we're going to put some pieces together here. And what I want to do is to give you some visuals to kind of help you out, and I'll explain these visuals as we go. Now the visuals build upon each other, so it's not like you start with one and then you're done and then the next one starts. You'll see different pieces of information added to kind of help you better understand everything together. So let's put this all together and hopefully get you some visuals for this. So the first thing is, in determining your outlier, before we get into all these visuals, you have to start with the operating and capital costs, right? What counts in all of these different costs, which is why an outlier, a non-utilization day, doesn't count into that because you don't have any costs for that day. They may not be there. Okay. Then you also have to look at the MSDRG payment. How much are you getting based on the costs and then the days that go together? So combining operating costs and capital costs needs to exceed the fixed cost threshold. Where do we get that fixed cost threshold? Remember, that was that DRG. that we looked it up. We had to go in, or not, that was where we had to go into DDE, the direct data entry, to get the DRG, to get the diagnosis-related groupings, the MSDRG, to make it all work together. Okay. You do need to make sure that all charges are on the claim. Sometimes there's a problem when you adjust claims later and some of the charges aren't there. It can cause other issues. So we want to make sure right at the end when you go to bill your final discharge claim, everything is on that claim. Everything possibly be on that claim. We don't want to have any other issues going on because that's going to definitely affect it. So we want to make sure you're aware of that. Payments on the remittance advice show with an MRG DRG out amount. Out being outlier. That's what the remittance advice will actually tell you. So this is above the actual IPPS MSDRG payment. So hopefully that helps you understand what you're looking for. So when you combine all of these costs together, that's what you want to see when you put it in with the diagnosis in the correct order. Primary, secondary, all of those diagnoses, all the resources used, how much money do you have to bill Medicare for? When you look at that, then you're going to put it through that pricer, and when the pricer comes up with an amount, then you say, oh, I do or do not have. Also then remember that you have to tell us the date that that was met. That's how we can calculate the additional payment. So hopefully that all makes sense so far. All right, so here's our first visual. It's talking about inliers and outlier days. This is the total length of stay, right? Doesn't matter if it is anything related to the patient itself being inpatient. Sorry, it does matter. It's the patient being inpatient. It's the time that Medicare is paying. And keep in mind, this is the total stay for that. Now, it doesn't matter if they have utilization days, remember, because it'll count both, although when we hit the outlier portion, there are certain things that figures in a little differently, and that's why we need those. Okay? So what will happen is we'll look up and we'll say, okay, this is when they were totally in the facility. We then look for a copay exhaust days. And you're going to bill that inlier payment, which is your full and copay days. Remember, that's 90 days, could be that additional. So you're going to make sure you get that billed to us. These are your inlier days. So even if the copay allows a full MSDRG, remember Medicare is still not going to pay you a per diem. It's still that copay. It's that entire thing, even though you may have the copay as a daily amount. So we want to make sure we have all of that. Keep in mind, when we talk about copay days, we also have to be aware that a copay is different amounts for the second set of copay days, which is the lifetime reserve days. It's higher, but you're still going to consider all those together. Okay. So then we move on and we say, okay, we got the copay days. Now here's this amount. This is when you're going to enter the 47 because this is the date that you reach that threshold. Please note, there's a longer time period, right? We know there's a longer time period. So we want some additional money. This is our outlier threshold. You can enter 47 on the claim telling us, hey, this is our outlier threshold. You're going to use the pricer because you got to determine how many days and when that threshold was there. All right. Then once you do that, then you're going to enter copay exhaust days. So these are just days when there's no more benefits left. These are days when, things are still within the MSDRG, because remember the MSDRG does not consider additional payments to say, hey, daily you get da-da-da-da-da. This is just when, hey, we exhausted all of our copay days. So this could be, again, at 90 or at 150, just depending on those elected days. Okay? So the outlier threshold's not reached. The date after the last copay day will be entered. Here's where you're seeing that. So we haven't met the threshold yet, so we're not getting an outlier payment. But we did meet the copay days. We're done with the inpatient days. Now your payment will still encompass those extra days, but we do need to know when that was done. Though they are covered as part of the MSDRG, means you don't get to bill the patient extra money. They are not considered utilization days because there are no more benefit days to pay for that. So those would be another example. Again, they're the exhaust days after that period is done. So there's another example or a good example of when we'd have non-utilization days. Okay, moving on. Now all of a sudden you say, oh, okay, Medicare may use full co-insert for lifetime reserve days. Using lifetime reserve days is not necessary. We want to make sure that's clear. But then we reach the outlier period. So this is all of this different days. So this goes beyond that. Here's the payment. Now, if the patient has absolutely no days left, then you're not going to apply this information because it's not going to work that way. And we know that because we can't post lifetime reserve days. It's going to be a benefits exhaust claim. That may sound familiar to some of you where you say, hey, the patient's still in the hospital, only, you know, there's nothing else going on. So we're going to reach an outlier day. Now, let's say they do have some additional days, and that's where you're going to build the outlier. So again, you're going to want to make sure you hit all these days, and you're going to make sure you hit this information in there. Some people said, do I have an outlier claim even if I don't have this co-insurance, the 70 in the middle? You could. You absolutely can, right? You don't necessarily have to have that. So you're just receiving an additional payment above the MSDRG. Other times what will happen is a patient may say, I don't want to use my lifetime reserve days, which means the 90 days exhausted. They start getting up into this outlier period where they've been in for a long period of time, and now they do want to use those lifetime reserve days. That's their option. They can then kick those LTR days in so they can utilize them here. But you will have those 70 where there's non-utilization days, right? Those current span code 70 for non-utilization days in the middle because the patient chose not to use their lifetime reserve days during that time period. Hopefully all of that does make a little bit of sense, get it all put together. So remember, the original payment, the MSDRG, covers the period of time up until the dollar amount is reached, just straight up until that dollar amount is reached. Once you reach that dollar amount, then you're going to go with the date. You're going to put that 47 occurrence code on there saying, here's the date that we reached our dollar amount. And again, that's the capitalization, all those things that you got to calculate together, right? So you want to make sure you have that in there. If you have all of that, then that will tell us that you need an additional payment. Now you need to make sure that we are using the correct days to we're utilizing the correct resources, the correct diagnosis codes, all of those items together. All right. Here is some information that I really want you to be aware of. I'm going to show you this page right here. This one is the CMS Outlier page. Again, these should be linked, which this one is not. The link is not opening for me. There we go. Sorry, it's going to take me a second here. But what this will do is actually talk about the outliers. It's going to talk about the payment. It's going to give you a lot of the background that I have, all of those different outlier amounts. Some of the information is a bit older on here, like here it talks about the 2005 files and all of that information. Remember that now CMS actually uses direct data entry. They utilize the system and you can go in and look at that. A common question or a question that we did get regarding that is, what if I don't have direct data entry? Then you do have to call customer service to ask that question and they'll have to look at it through the system to see if they can get you that. It's how it works when all of that goes together. We don't have another option for you with this pricing system. So that's another question we wanted to ask. So you can read through all this information. It's going to talk about all those different portions with Outlier. I do think it's some great information, and I really would encourage you to look at that. Let's jump back to the slide for a second. If you want the actual Medicare instructions and how we process the claims and all the information that we have to do, I've given you that as well, and you can see there's 2 different sections listed. Go ahead, select that link. It will open directly to Chapter 3, and then you just have to search 20.7.4, or you can scroll down to it, and it's going to take a little bit to get there. That's cost outliers. Okay. The other section, which I don't remember, was 40.2.2, and again, you'll just scroll down to 40.2, and then you go to 0.2, and so then you can see what you can charge the patient for. So the cost outlier doesn't directly affect the patient liability amounts because remember, patient liability amounts are done a little differently. They're done on copay days. So they've already been charged the copay, and a copay occurs in an entire span of time. So it's the deductible first, then 100% paid by Medicare, then the copay days, then the lifetime reserve copay days. But it's all done by a flat fee. Either you're getting an additional payment, it doesn't affect, it's not a percentage like a Part B services. So you want to make sure you're aware of all of those different information. But this is also important because this talks about the coverage utilization rules. So this is about some of those copay things, and which is why I wanted to make sure you had that, because it also then talks about this type of information. So if you're looking for what, all of the non-covered days, all of those different things that I was talking about, the non-utilization review days, definitely take a minute to read through some of this stuff. It'll help you understand some of the different pieces here. All right, so that brings us on to the questions. Oops. So as I said, I've covered most of the questions I previously received, or hopefully did a good job with those for you. So if you have a question that I haven't covered that you sent in, put it back in the chat for me. I'm going to ask Ellen if we have any questions in the chat at this time.
Tom, the only question that we have received so far is, and I think you've answered this, but you tell me, what are some examples of non-utilization days?
Sure, and I did. I tried to answer this, so hopefully I got this one up. If I didn't, put it back in the chat. But examples would include things like the end of a day when the benefit period is still going on. There's a total benefit period, but the patient's no longer receiving payment from Medicare for that Part A stay. So maybe the patient elected not to use their lifetime reserve days, which means there's a set number of days and it's done. So that's 90. Once they reach that 90 days, though they're still inpatient and though those are still covered under the MSDRG, because remember, it's not a per day basis, it's a full payment basis based on diagnosis code, the non-utilization days would be the days after that 90 days lapses. So that's what that's an example of a non-utilization day. Another example I gave you was that hospital, or you don't have, for whatever reason, something to do like a sleep study, and you need to send the patient out for a day for just a sleep study, so they're on a leave of absence from your facility. Though they're technically still a patient there, they're just not getting paid for that day, or we're not looking at utilization resources for that day because they're at another facility at midnight. A sleep study is probably one of the best ones I have for that. But it is an example where the sleep study is billed independently and separately, depending on how the IPPS, and depending on whether they put them on a leave of absence, whether they discharge them, whether they said, no, just bill us the sleep study, we'll throw that onto ours. It all goes together into a variety of factors. So hopefully I answered that well enough for non-utilization days. Again, please feel free to put that back in chat if I did not or I missed something you'd like there. All right. Any other questions?
Tom, we don't have any more questions at this point.
All right, perfect. So that's the end of the information today. Again, take advantage of the survey if you can. I really like your feedback, but I'd also really like what you want in the future. Give me any comments, good, bad, ugly, all of that kind of stuff we want to know. Watch for that proof of attendance certificate. Should be coming out in about 20 minutes or so. If you don't get it by the end of the day, drop us an email. So thanks everybody for attending. We appreciate your participation in this event, and we hope you found this information helpful. Everyone have a great day. You may now disconnect.